options, right? So we'll be particularly also privileged to have our distinguished senior faculty, Professor Raji Mahmood, with us, whose experience and perspective will also enrich this discussion. The YNNF has remained committed to academic excellence, collaboration, and mentorship, and we hope that today's session will stimulate meaningful discussion and practical insights for our daily practice. So we hereby will call on the first speaker, Dr. Ibukun John, who will take us on the clinical case, relevant anatomy, pathophysiology, and clinical presentation. Please, you have 30 minutes to do this. Please go ahead, please. Thank you. You can start the presentation, okay? Okay. I don't know if it's just me, but I can't hear anybody.
Dr. John, your mic is muted. You are not, we can't hear you. You need to unmute your mic, please.
Hello, sir.
Yeah, okay. We can hear you now. You can go ahead.
Oh, okay. Sorry for that. So I will start with a quick presentation. First case is that of this year, a 50-year-old female entered with altered for 4 hours following root capital. The lost consciousness, which was partially redeemed and initially bled from the right later transition clear discharge. They also bled from the right nose. Had no seizures or depression, and no injuries to other parts of the body. On examination, she was a young woman with other consciousness, not clearly febrile, 5 centimeters, scalp laceration, vital signs were shown. The admitting GCS 10, pupils were 3 millimeters exterior. They had right cranial and 7 palsy, lower nostril right side out from number 3, and blood mixed with blood with fluid was noticed from the right ear, which later became clear in the left side target is present. The investigation were shown essentially normal. The beta transferring done this scan shows transverse fracture of the petrous bone, and also acute ventricular contusion of the frontal lobe. Diagnosis was moderate traumatic brain injury with middle basal skull fracture and hemorrhagic contusion complicated by right excessive arterial. She was managed non-operatively and placed on bed rest, had of mass. It was placed on stabilized 2 milligrams QDS. The arterial resolved 5 days post-trauma. She was commenced the addition therapy, and she was discharged 15 days post-trauma, and she is currently on RTC follow. The second case, that of OO, 19-year-old male, presented with current headache of 7 months, watery nasal discharge for 4 months. It was recurrent, insidious, generalized throbbing, once in the morning, with visual analog score of 7 at 6, non-radiant. Also, notice was hair watery nasal discharge with nasal drip and salty sensation. No seizure or altered consciousness.
Yeah. Dr. John, it's difficult to hear you well. I don't know, is there a way you can improve that?
Okay, sir.
Your voice is not clear.
Okay, sir.
Okay.
Hello, sir.
Yeah, okay, go ahead.
Okay, sir. There was no preceding trauma or on examination, the vital signs are shown. The GCS had no cranial neuropathy, no signs of restriction, no tract, or intact. The Savoy sign was shown in the picture. And see the watery nasal discharge rushing onto his palm. The sagittal cranial CT scan shows markedly dilated lateral and third ventricles with a normal fourth ventricle. The aqueduct of Sylvius is not obvious, and there is bulging of the third ventricle into the stellar testicle. And the yellow arrow shows the portion of the frontal horn communicating with a defect that is shown by the blue arrow. There's a defect in the posterior wall of the frontal sinus that's communicating with a frontal horn, the portion that. And we can see within the frontal sinus there is air fluid level showing that CSF is passing into the frontal sinus. Diagnosis was active encephalus secondary to accidental stenosis, complicated CSF. The check had system diversion with ventriculoperitoneal stents, which was what was available in our center with progressive resolution of area. The management of these patients was hampered by severe financial constraints, and patient opted for discharge despite counseling on CSF fistula repair due to financial constraints.
Sorry, Dr. John, are you using earpiece?
Presentation proper, which is
hello.
Hello, sir.
Are you using an earpiece?
No, sir.
Okay, because you're not just very audible, it waxes and wanes. So people might find it difficult to follow you.
Yes, sir. I will try to increase the volume of my voice.
Okay. All right.
Cerebrospinal fluid leak or fistula refers to any destruction of the arachnoid and dura that allows CSF to escape to the extradural space. This can occur anywhere along the craniospinal axis, and the most common clinical manifestation is CSF rhinorrhea, followed by otorrhea. Leakage along the spinal pathways can cause severe postural headaches, and occasionally there may be recurrent bouts of bacterial meningitis, and this may be the only presentation of the patient. Trauma accounts for most cases of CSF fistula, and over 50% of them present within 2 days of trauma, and about 70% will present within 1 week. 2 to 3% of all patients with head injury will develop CSF fistula, while it's even higher, the incidence is higher in those with basal skull fracture, about 11 to 45%. 60 to 70% of CSF rhinorrhea will resolve within 1 week, and this CSF fistula is rare in children. Anosmia is common in traumatic leaks due to traumatic injury to the cribriform plate, which and then also transmitting the olfactory nerve filaments. And anosmia is rare in spontaneous causes. The lifetime meningitis risk for untreated CSF fistula is 25%. Historically, in 200 BC, Galen described CSF leak after cranial trauma, and in mid-17th century, it was first considered a pathologic process. In 1826, Miller noted visa flow or clear fluid in a child with hydrocephalus, and in 1923, Grant first proposed closing it with a traumatic dural effect. In 1926, Dan reported the first successful operative repair of a CSF leak, and several decades later, a lot of research still going on, and even up till now, that diagnostic techniques are still evolving. Classification of CSF was classified by Cairns in 1937. He classified CSF rhinorrhea into acute, delayed, traumatic, operative, and spontaneous. And then the spontaneous was further subclassified into primary, spontaneous, and secondary spontaneous. Omaya et al. In 1968 classified cranial CSF according to the table shown into traumatic and non-traumatic. For the traumatic, into accidental and iatrogenic. For the non-traumatic, classified into high pressure leaks and normal pressure leaks. The high pressure leaks are from tumors or hydrocephalus, and while the normal pressure leaks may be from osteomyelitic erosion, congenital anomalies, and focal olfactory or intracellular atrophy. This table summarizes the different etiology of CSF fistula. It could be congenital and acquired, and under acquired could be idiopathic, traumatic, inflammatory, or from neoplasm, as depicted on the table. The anatomy from inside out, talk about the meninges. The meninges are three parts: the dura mater, the arachnoid, and the pia mater. The dura mater, the cranial dura, has two parts, which is the parietal and the meningeal part. Between the arachnoid and the pia mater is the subarachnoid space, which houses the cerebrospinal fluid. And the skull base, the anatomy of the skull base is also very important, because the skull base is divided to the anterior, middle, and posterior cranial foci. And there are some parts of the skull base that are very thin and prone to fractures, or they are prone to fractures or could be easily eroded by infectious processes. This picture shows us some of those thin, bony parts of the basal skull that are very important, prone to that could be implicated. These include the piriform plate, which forms the roof of the. It actually separates the anterior cranial fossa from the nasal cavity, and it has multiple foramina for olfactory nerve. It's a thin bony plate that is prone to fracture. Also, the fovea ethmoidalis, this forms the roof of the sinus sinus, and also the frontal sinus. The frontal sinus is also has communication into the communicates with the cavity through the nasal duct. And the sphenoid sinus, which is also very important, is just superior to the nasopharynx. It opens into the nasopharynx. Also, we can see the eustachian tube orifice is also located within the nasopharynx. And all of then for the middle cranial, the middle cranial fossa is separated from the middle here by the segment tympani. Is a thin bony structure just over the middle ear, and fracture of this bony structure can lead to CSF leak into the middle ear, which could from the middle ear could come out through the external auditory canal if there is ruptured tympanic membrane, or if the tympanic membrane is intact, it moves through the eustachian tube into the nasopharynx and comes out as rhinorrhea. That's what we call paradoxical rhinorrhea. These are possible routes of CSF leak to natural hair cells, especially following pituitary surgeries like vestibular schwannomas, sphenoid hair cells, piriform plates, or ethmoidal roof, frontal hair cells, and then Sometimes it's percutaneously through a surgical or traumatic wound. Cerebrospinal fluid is contained within the ventricles of the brain, which the cranial and spinal subarachnoid spaces. Most of the CSF is produced by choroid plexuses of the lateral ventricles and the third and fourth ventricles, according to the workflow model. And the production rate is about 2.3 mils per minute, and about 42 mils is produced in 24 hours. Clear, colorless, has a specific gravity of 1.007 and a neutral pH. For CSF to occur, there must be destruction of barriers or destruction of barriers. And these barriers are the meninges, the dura, and the arachnoid. There must be a destruction of this. And also, there must be a destruction or a bony defect, either a fracture or a congenital defect of the bones, especially those the bones that we have talked about, the frontal, the ethmoidal bones, and sphenoid bones, and bones that make up the middle cranial fossa and posterior cranial fossa. And there must also exist a pressure gradient, such that the pressure gradient causes the CSF to flow from the region of high pressure to an extradural space of low pressure. Clinical presentation will be according to the site or according to timing. According to site, it will be cranial or spinal in origin. And for the cranial ones, it could be a fracture to the anterior, middle, or posterior fossa. And timing could be they could present acutely, especially in traumatic cases, or they could present as chronic cases. And the common history that is gotten from them, a history of proceedings come up with the head.
Yeah.
And for those who...
Sorry, Dr. John, is there something you can do about your audio?
Yes, sir.
Please, it fluctuates. So people are not following very well. I don't know whether it's from your network.
I'm working on that.
Please do.
Dr. John, are you using laptop to present and to
Yes,
talk
sir.
at the same time? So
Yes,
you can
sir.
use phone. You can use phone to talk and use your laptop to show your presentation. Otherwise, we couldn't really make anything out of what you were saying. Is anybody there to assist?
Yes, sir. We are working on it, sir.
All right. Thank you.
In the transmission. So clinical presentation, this patient may present with hello, sir.
Yeah, it's very good now. Please go ahead.
Hello, sir.
Yeah, it's very good now. Go ahead, please.
Hello, sir.
You can go ahead. Hello, are you there?
Hello, sir.
You can continue. Go ahead with the presentation.
Hello, sir.
Hello, we can hear you. Go ahead with the presentation.
Okay, all right.
Are you still talking to us?
So the clinical presentation for those who have anterior skull base or from anterior skull base leak would have clear watery nasal discharge that is positional in origin, worsened by Valsalva maneuver, and maybe positional in pattern, maybe exacerbated.
We stopped hearing anything.
Yes, I think we lost her, but she's back. Please continue. You can unmute yourself, please.
Hello. Hello, sir. Can I hear?
Yes, but speak up, please.
Oh.
We can't hear you. Or maybe you should put off your video to see whether it will help.
Yes, sir.
Is the co-presenter around? Maybe.
Yeah, I think they are using the same laptop. So
I'm working on that.
Oh, okay.
I think they are together.
All right. Hello, ma'am.
Yeah.
Yes.
Yes. All right.
Yeah. So we can hear you now. You can
Yeah.
continue. Thank you.
All right, ma'am. So we're talking about the clinical presentation of the patient. It could present with CSF rhinuria, which would come as clear watery nasal discharge, which is worsened by Valsalva maneuver, and patient may describe soft or metallic taste with nasal drip. Patients may come with septic bacteria in which there will be clear watery air discharge through the external auditive canal. It may coexist with conductive hearing loss or tinnitus, and it may follow temporal bone fracture or neurologic surgery. Patients may come with symptoms of intracranial hypotension, such as orthostatic headache, neck or back pain, nausea, and dizziness. And additionally, they may also present with cranial nerve ulcers, especially cranial nerve 1 and cranial nerve 7. Rarely, there may be oculorhinuria if there is disruption of the conjunctiva. There is an atrial skull-base fracture and disruption of the conjunctiva. So, patients may come with some of complications of like meningitis. The presenter present with fever, headache, sad mental state, meningism, and meningitis could actually be recurrent, especially for weeks. And patients may also present with tension in hematocephalus, presenting with headache, deteriorating consciousness, and cardiorespiratory arrest. An examination, they could have signs that are telltale signs of basal cell fracture, like open eyes, like battle sign, and examining the nasal cavity, there may be cleft in the nasal passage or evidence of prior surgery or penetration, and examining maybe cleft pulling in the external auditory canal, and the tympanic membrane may show clear or slightly xanthochromic fluid behind it, and there may be a mastoid wound with clear drainage subjectively. Reservoir signs may be demonstrated. There is arterial structure with pulling of CSF into the.
Your voice has gone back to how it was before.
Hello, sir. Can you hear me, sir?
Yeah, we can hear you, but it fluctuates. It waxes and wanes. It goes down.
Sorry about that.
Okay, Maria.
Yes, sir. So the reservoir signs can be demonstrated in them, and then sometimes they also present with hello. They could also present with cranial palsy, especially cranial 7, like we can see in this. Sometimes may just cleft discharge from the previous site of surgery, especially in or following spine surgery. My co-presenter will now continue from here. Thank you.
Can you put off your video, please, to see whether it will help? Okay. All right. Are you done?
Yes, sir. My co-presenter will.
Okay. Thank you very much, Dr. John, for that presentation. Before the second presenter starts, I think we need to work on this audio so that people can really follow. Have you been able to rectify it? Have you been able to work on that?
Yes, sir.
Yeah, because with time, it just goes down. We won't hear anything, then fluctuates, people are no longer following. So if you
Yes, sir.
can video to see whether it will help. I guess you are having some network challenges.
Yes, sir. Sorry.
So are we good?
Yes, sir. We are.
All right. So thank you for that timely presentation. So we'll move on to the second presenter, who will take us on the evaluation and treatment options, Dr. Adedoyin.
Thank you very much, sir. Standing on existing protocol, I'll be continuing the discussion. So treatment and evaluation and treatment of CSF fistula is multimodal and multidisciplinary for successful diagnosis as well as treatment of CSF leaks. The goals of evaluation are to confirm that the fluid is CSF, to identify the site of origin of the leak, as well as to determine the etiology or mechanism. So to evaluate the evidence of the presence of CSF, there are clinical clues that could suggest that the fluid could be CSF, one of which is clear. A fluid that is clear, usually from just one nostril, could suggest that this could be CSF. However, in the setting of acute trauma, this could be admixed with blood or infected. And then CSF fluid does not cause nasal excoriations or irritations as compared to nasal mucus. And then CSF fluid have a salty taste. So there are some bedside presumptive tests that can also suggest the presence of CSF, one of which is the halo or ring sign. So the halo or ring sign, when fluid is dropped on the white lining, a ring of blood with a larger concentric ring of clear fluid, called the double ring or halo sign, suggests the presence of CSF. Blood stays at the central and then CSF migrates to the periphery as a result of the differences in densities of this fluid. It is an old but unreliable sign. It has a high false positive rate and cannot be reliable as a standalone test. It has to be used in conjunction with clinical correlation as well as imaging studies. The handkerchief test just describes stiffening of clothes when CSF is dropped onto the clothes. And this is because CSF is non-viscous, it has no mucin, as compared to nasal mucus that stiffens fabric because it contains glycoproteins. The reservoir sign is a gush of fluid that occurs with a certain head position and is most common after first sitting up after a period of recumbency. It is thought to indicate the drainage of CSF pooled in the sphinal sinus and is not a reliable sign. So there are some biochemical tests that can also be done to evaluate CSF fistula. Quantitative glucose level can be assayed with the use of exokinase or glucose method. For normal CSF level, it contains a value of more than 30 milligram per dl, while lacrimal secretions are less than 5 milligram per dl. It has a false negative in CSF hypoglycemia, and it is also unreliable. If the fluid is tears, blood, or even normal nasal secretions, this can cause a false positive value, and it's not something that one should rely on as a clinical or bedside test. So the gold standard biochemical test is the beta-2 transferrin. This is a carbohydrate-free isoform of transferrin, and it's found only in CSF perilimbs as well as vitreous humor. It is assayed via the use of immunofixation electrophoresis. It has high sensitivity and high specificity. However, the limitations are that it requires 0.5 to 1 ml of fluid, and it is difficult to assay in low-flow CSF leaks. It also uses a manual process. It has a longer acquisition time, and it could also be falsely elevated in patients with chronic liver disease. An alternative to the beta-2 transferrin is the beta trace protein, a prostaglandin D2 synthase that is assayed via an automated method. It also has high sensitivity and specificity, and the advantages over beta-2 transferrin is that it has a shorter acquisition time, it requires very little sample, and it is less prone to human errors. However, the limitations are that beta trace protein exists in low concentrations in normal blood, and then it can also rise, the BTP levels can rise in patients with renal failure. So the recommendation is that one should measure the BTP in the secretion as well as the serum simultaneously. And that ratio of more than 2.0, that is a ratio of the secretion to the serum ratio of more than 2.0, confirms that this leak is truly cerebrospinal fluid. A ratio that is less than 1.0 is suggestive of blood contamination or mucus, while a ratio between 1 and 2, known as the gray zone, requires further clinical correlation. This table shows the differences between B2 transferrin and beta trace protein, as I've said earlier. So one of the goals of evaluation is also to identify the site of origin of the leak. For cranial leaks, initial imaging studies are usually an high-resolution cranial CT scan. These are done as ultra-thin slices of axial and coronal views. And what can be found on these are discrete bony dehiscence, air fluid levels in sinuses, pneumocephalus, and they are excellent for trauma because they are fast, they are widely available. However, the limitation of this study is that cannot distinguish between a bony defect and an active dural tear. So then, what is the gold standard? The water contrast CT cysternography is regarded as the gold standard because it gives dynamic information. It's indicated when on plain CT scan, there is no site identified, but the patient has clinical leaks, or there are multiple bony defects, but it's difficult to isolate the source. And then the bony defect on CT, there is a bony defect on CT, however, without abnormal adjacent brain enhancement. The procedure involves doing a lumbar puncture, introducing ioexol 6 to 7 mils into the lumbar subarachnoid space. Using a 22-gauge spinal needle, patient is positioned trendilebar, and the neck, front and the neck is flexed. In this procedure, provocative measures to increase valsalva maneuvers or intrathoracic pressure just to increase the yield of this study can be done. A brain MRI with contrast is another imaging study that can be done, T2 weighted sequences. It can show water column by visualizing a continuous bright signal CSF from the subarachnoid space into a sinus, as well as showing if there are soft tissue herniating through a bony defect. It can also give information, additional information on localization, and it could help rule out P-fossa masses or masses that are causing obstructive hydrocephalus that could be a cause of the CSF leak, or in patients with idiopathic intracranial hypertension and MTCLR on imaging. Other studies are MRI cysternography. Older studies just for educational purposes are radionuclide cysternography, which have a poor localization, as well as intrathecal dye test. So other studies done are plate studies, and this involves the use of tracers like non-radioactive as well as radioactive tracers. And it gives a categorical proof of CSF fistula, the ability to retrieve extracranially a tracer that has been injected into the cerebrospinal fluid via a lumbar puncture. So cutting plates are usually placed in specific anatomical locations, and substances that are used are non-radioactive as well as radioactive substances. The non-radioactive substances used include indigo carmine, and fluorescein, and it said that these have remained in common use for intraoperative visualization. Fluorescein use as, however, fluorescein use, there are reports of transverse myelitis as well as other serious adverse events, such as seizures with fluorescein use. However, indigo carmine has a safety record because it is more visible than fluorescein to the unaided eye. So this table shows the location of stain and then the probable site of fistula. So if the plate stains in the anterior nasal, it suggests a cribriform plate or anterior ethmoidal roof. If it stains in the posterior nasal, it suggests a posterior ethmoidal or sphenoid sinus site. And then middle meatus suggests a frontal sinus site. For spinal leaks, imaging studies are CT myelograph and then digital subtraction myelography. CT myelography involves the intrathecal injection of non-ionic contrast followed by CT. And then once one is able to identify a puddle or contrast extravasation at the site of the leak, it suggests the possible site of CSF leak. It is highly effective for high flow leaks. The digital subtraction myelography is actually used for some special types of spinal leak called spinal CSF venous fistula, which is an abnormal communication between the spinal subarachnoid space and paraspinal veins. Is indicated when there are cases of intracranial hypertension where a leak is suspected but is not found on CT myelography. So how do we treat this condition? Cranial leaks initially should be treated with conservative measures. The indications for this are acute post-traumatic leaks, because most of these leaks stop and cease. About 70% of cases of traumatic CSF rhinorrhea stop within 1 week, and usually within 6 months in the rest. And most traumatic CSF autoria ceases in 5 to 10 days. So acutely after trauma, observation is justified, as most cases of the CSF leak cease spontaneously. Patients are placed on bed rest. The head is elevated to reduce the intracranial pressure, and then measures are taken to avoid raising intrathoracic pressure, to avoid straining by use of stool softeners, avoid nose blowing. Use of acetazolamide can also be used to reduce CSF production. And in cases where patients present with leaks from their nose or their ears, patients should be advised not to block these leaks, because this can cause stasis and increase the risk of meningitis. The next step for treatment for cranial CSF leaks are lumbar drainage, which can be used as intermittent or continuous drainage. It is found useful in controlling and sometimes even curing CSF leaks. And the indication for therapy are when there are a failed conservative management. It can also be used to measure the opening pressure in patients that are suspected of having spontaneous leak. And other uses of lumbar drainage are intraoperative intrathecal fluorescein administration for localization intra-op for brain relaxation via when the patient is undergoing maybe an open transcranial approach to their cranial leaks, graft protection post-op in high flow leaks. The risk of lumbar drainage are tension hemocephalus when the drainage bag falls to the ground. So one should avoid this because it's a possible potential life-threatening complication of lumbar drainage by ensuring that the bag is placed at the level of the shoulder. And one of the other complications of lumbar drainage is suboccipital and subdural hemorrhage with overdrainage, as well as dural cutaneous fistulas. The use of prophylactic antibiotics for CSF fistulas is controversial, and routine prophylactic antibiotics are not recommended for blunt traumatic CSF leaks. Meta-analysis of randomized control trials shows no significant differences in the incidence of meningitis or all-cause mortality or the need for surgical correction. However, one can consider the use of antibiotics prophylactically for patients who will be undergoing elective skull-based surgeries. This is a level 1 evidence, or patients who have penetrating trauma, such as gunshot wounds or high-velocity wounds. And then in high-risk hosts, maybe patients with immunocompromised states, or those who have existing hardware even before this condition appears in them. So the duration usually used for 24 to 72 hours maximum, and evidence does not support continuation until the leak stops. One of the arguments against the use of prophylactic antibiotics are that it can increase the risk of multi-drug resistant strain selection. It could have a masking effect, especially when patients now have fulminant meningitis, because it reduces their systematic response, to this infection. And then most of these drugs they have poor CNS penetration at the initial start when they are used, so they are not recommended because of these reasons. There is a shift towards vaccination for streptococcus pneumonia, which is one of the most common causes of meningitis in patients with skull-based defects, and is indicated for cranial CSF leaks, chronic skull-based defect, and is ideally administered 2 weeks before elective skull-based repair. A single dose of PCV20 can be used, as well as alternative or sequential use of PCV15 followed by PPSV23, and also expanded coverage for Haemophilus influenza as well as meningococcal infections can also be done. The timing in trauma is that it should be given as soon as the patient is stabilized, and then late vaccination within 10 days of injury can also be done, as it has been shown to significantly reduce the risk of infection. However, to note is that it does not eliminate the risk of meningitis from non-vaccine strains or gram-negative organisms, so that it does not give a false hope, to the patient or the clinician. Operative treatment for this condition is indicated when patients have persistent leaks or penetrating trauma, high-pressure leaks, or leaks that are associated with congenital dysplasias or post-op rhinorrhea and otorrhea. And this graph shows this various approaches to surgical management of CSF leaks. It could be intracranial or extracranial. Intracranial approaches can be intradural, extradural, or combined approaches, while extracranial approaches can be open or endoscopic. The choice of approach depends on the site as well as the cause of the leak, as well as the location of the defects. Major cranial operative approaches are via craniotomy, intradural and extradural techniques, extracranial techniques, and CSF shunting procedures in patients that are indicated for. So the intradural approaches for anterior cranial fossa leaks include the bifrontal craniotomy. So the intradural approach is generally the procedure of choice. If the fistula site is unidentified preoperatively, one should use a bifrontal bone flap. And general techniques of the intradural approach would include resting the peritoneum as a separate layer from the flap for possible reconstruction at the skull base. And then general techniques also include closing the bone defect with fat, muscle, cartilage, or bone, and then closing the dural defect with facial lateral temporalis muscle fascia or pericranium. Intra-op, if the leak has not been identified preoperatively, visual indicators of the leak could be a palpable or visible dural defect. There could be adhesions at the site of the possible site of the leak. There could be focal cerebral contusion following trauma, and there could also be cerebral tissue herniation through the bony defect. Dural repair can be done primarily or with the use of patch or patch graft. However, in most cases, meduloplasty is usually done. And a watertight tension-free closure is the gold standard. The fundamental principles are to restore the integrity of the dural matter, to prevent the CSF leak from recurring, and to maintain intracranial pressure and avoid infection. If no discrete fistula is visualized intra-op, the entire floor of the frontal fossa is invested with a large pericranial graft. And the integrity of the repair is tested via Vassava, where the anesthesiologist is instructed to increase the intrathoracic pressure to look at the site if there is any leak. For middle fossa leaks, subtemporal craniotomy are used, and posterior fossa leaks, erythrosigmoid or suboccipital craniotomy are used. And then combined approaches can also be indicated, where intradural as well as extradural techniques are also used. For leaks into the sphenoid sinus or following transsphenoidal surgery, one could first do a lumbar puncture, which could be intermittent or continuous, especially when the pressure is more than 150 millimeters of mercury or xanthochromic CSF is found. And if the leak persists for more than 3 days, one should repack the sphenoid sinus with fat or muscles or cartilage and or facial latter. Usually muscles are not advised because they can shrink with time, and usually the best ideal method should be with the use of fat. Also, the floor of the cellar should be reconstructed, and then lumbar puncture should be continued post-op for 3 to 5 days. If the leak then persists more than 5 days, one should rule out the possible obstructive hydrocephalus. And once this is ruled out, other options could be to do a transnasal cellular injection of fibrin glue under local anesthesia. Okay, so for posterior fossa, post-posterior fossa surgeries, a tiered approach can be done for these cases. However, most times the patient should be re-explored for their leaks. A conservative management, including bed rest and positioning, and then avoidance of strain and wound care, especially when there is an incisional leak, by oversewing the leaking portion of the wound or applying a pressure dressing for some days. And then also to notice that CSF diversion could be indicated where there is an obstructive hydrocephalus, especially following P fossa surgeries. And then surgical re-exploration should also be done. In surgical re-exploration, the principles are that a persistent post-op CSF leak that is diagnosed, prompt reoperation is recommended rather than relying on conservative management. So a watertight dural closure is done. A multi-layer closure technique, a layered approach is generally necessary to ensure durability. And then one to note is that occlusion of mastoid hair cells, which could have been transverse or which could have been passed through in the initial surgery, should also be rewaxed rather, to prevent reoccurrence of this CSF leak. So post-op, patients would need concomitant CSF drainage, and then any underlying hydrocephalus should be addressed, whether via shunting and procedure with the use of VP shunts or EVD if the patient cannot undergo VP shunt surgery at the time it was seen. Okay. So extracranial approaches are indicated when there are discrete, definable normal pressure leaks through the cribriform plate or the adjacent ethmoid labyrinth, when there are fractures that are built on air sinuses, or post-op leaks after transsphenoidal surgeries, or leaks through other sites such as the vulvar window, petrous bone, or other parts of the ear. The endoscopic endonasal approach is currently now becoming one of the gold standard for most anterior and middle skull-based leak, and it offers a 90 to 98% success rate. The use of vascularized pedicled nasoseptal flap are now being used, and this is based on the pedicule on the nasoseptal artery, which is a branch of the posterior septal artery. So for graft placement techniques, we have different techniques: the underlay, the overlay, the multi-layer technique, obliterative technique, as well as bat plug technique, which are what are described in this diagram. So for the underlay technique, the graft is usually tucked between the bone and the dura, and these are preferred for larger defect more than 3 mm, as intracranial pressure helps to stabilize the graft against the bone. The overlay techniques involve the placement of the graft over the dural lesion, and the exposed bone margins, and this is actually typically used for smaller defects. A multi-layer technique can combine the use of both underlay as well as overlay grafts for a sandwich effect, and this is often necessary for high flow leaks as well as large defects. Obliterative techniques where the sinus cavity can be filled with fat to prevent recurrences are typically used in polypneumatic sinuses, and then a fat plug technique where a fat plug with a suture is pulled through the defect. So usually the fat plug is usually wider than the defect and then is pulled through to seal it from the inside as a bathtub plug. For spinal leaks, management include initial conservative measures, and these are usually indicated for mild or acute cases where the patient is placed on bed rest, usually in a flat position. Aggressive hydrations are usually done, and then caffeine are used to stimulate CSF production, especially for patients who might be having a complication of spontaneous intracranial hypotension. A direct surgical repair can be done where the leak is directly identified by a primary dural repair or the use of grafts, which could be augmented with fibrin glue adhesive. The epidural blood patch was first proposed in 1960 by Gormley and was developed after observing that bloody dural punctures had a lower incidence of subsequent headaches. So epidural blood patch can actually be used as a method to treat spinal leaks as a targeted or a non-targeted technique. In targeted epidural blood patch, the injection is usually done at the exact site of the leak. And this could be in the thoracic region, the cervical region, and it has a higher first attempt success rate, sometimes exceeding 87%. In non-targeted epidural blood patch, these are typically performed in the lumbar region, and it has a lower initial success rate. Recent meta-analysis suggests that it remains a viable option as first line. And it's been shown from studies that success rates improve with larger blood volumes. So if the volume of blood used for the patch is about 20 mils, 96% success rate has been recorded as compared to smaller volumes lesser than 20 mils, in which only 70% success rates are seen. For CSF venous fistula, where there's an abnormal communication between the spinal subarachnoid space with a paraspinal vein, options of treatment are surgical ligation as well as endovascular embolization with the use of onyx. Post-op care include the use of lumbar drain. However, this is also controversial. So some feel that the CSF pressure may help to enhance the seal, and as such, lumbar drains should not be used. And in some cases, some recommend the use of lumbar drain to help to encourage also that the seal be adequate. So the lumbar drain should, if used, should be placed at the level of the shoulder to prevent the complications of tension in hemocephalus that could occur when these drainage bags are not appropriately placed. And then positioning, depending on whether it was a cranial leak or a spinal leak, would differ. So for cranial leaks, they're usually positioned head up, while for spinal leaks, they're usually positioned supine. IV antibiotics are generally used post-op, and then we want to avoid straining with the use of stool softeners and other measures. Outcomes for CSF fistulas are have a best prognosis with trauma because more than 80% of them spontaneously close. And spontaneous leak have the highest recurrence risk due to underlying pressure. Usually, spontaneous leaks are usually from idiopathic intracranial hypertension, high flow leaks. And so the rate of recurrence, it has the highest rate of recurrences compared to traumatic leaks. And with conservative management for traumatic leaks, they have a high success with resolution within 7 to 10 days. And then endoscopic repair has a primary success rate of 90 to 97%. Complications of CSF fistulas include meningitis that occurs in up to 25% of untreated traumatic leaks, tension in hemocephalus, spontaneous intracranial hypotension, as well as other complications are shown. The future trends for management of CSF fistulas have included the use of advanced imaging and molecular diagnostics, where there is real-time imaging to show the CSF leak as it goes. And then bioengineering and regenerative grafts has also been used, which stimulates the regenerative processes of the body. So in conclusion, craniosspinal cerebrospinal fluid leaks are serious, often debilitating conditions. They are caused by dura mater and arachnoid breaches, and prompt identification to prevent life-threatening complications like meningitis or severe intracranial hypotension is needed. While many trauma-related leaks resolve with conservative management, chronic or spontaneous leaks often require specialized imaging for localization as well as definitive repair. So these are our references. Thank you for listening.
All right, thank you very much, the two presenters, Dr. Ibukun and Dr. Adedoyin, for the wonderful presentations. I think they've done a very good job with the first presenter taking us through the case presentations. They had two cases through the historical perspective, the classifications, relevant anatomy, possible routes of the CSF leak, the CSF dynamics, and the clinical presentation. While the second presenter took us through the evaluation of patients with CSF fistula using the bedside test, the laboratory test, and also finding out the site of origin of the leak using imaging, and also talked about the Puget studies. And then in treatment, he told us about the conservative means, the role of the lumbar drainage, the possible use of prophylactic antibiotics, and also the use of vaccines in prevention of infection. Then talked about the surgical approaches, the intracranial and the extracranial approaches. And she didn't forget about the spinal leaks and also the treatment using the conservative direct surgical like repairs, and then the use of epidural blood patch. She went ahead to tell us about the post-operative care, the outcome, and the complications. I know some of us will have one or two questions to ask. Please, if you have any question, do well to ask, indicate by a raise of hand, and direct it to the presenter. Is there anyone? There is no question in the chat box. Does anyone has? Okay. Someone asked, how do you taste if CSF is salty? How do you know if CSF is salty? Okay. Or maybe you would have phrased it better. How do you know if it's salty? It's more like someone taking salt. All right, so I'll leave it for the presenters. So the person that took us on the clinical presentation, Dr. Ibukun.
Yes, sir.
Okay.
Okay. Knowing how the CSF prevents salty, the patient will tell us that he feels like he's feeling some sensation in the throat and it's salty. So the patient gives the information.
All right. Well, I didn't get what you said clearly. We usually have problem with your audio. But
if they are in the same, Dr. Ndukuba, if they are in the same place, she can use Dr. Adedoyin device.
Yes, sir. We are together, sir. We are together, sir. Yes.
Hello, sir.
Okay, go ahead, please.
Okay, sir. I said the patient will give
At this point, I think it's from your voice. All right. Thank you very much. I don't think there is any other question at this juncture. I think we need to call on the...
I think there are moderator,
Sorry?
sir. I think there are some questions or comments there about. I think somebody just posted something now.
Okay, all right, okay. It's okay. Someone asked. Okay, yeah, I've seen that. How do you make a diagnosis of hydrocephalus in a patient with persistent CSF leak, particularly if high volume leak? How do you make a diagnosis of hydrocephalus in a patient with persistent CSF leak, particularly if high volume leak? That should go to the second presenter.
Yes, sir. Thank you for the question. So to suspect hydrocephalus in a patient that has persistent CSF leaks would include the use of various methods. So because this leak is actually persistent, that could suggest that this could be from an high flow leak. And then imaging studies, usually with the use of CT scan, will show ventriculomegaly, Evans ratio greater than 0.3. It would also show presence of periventricular hypodensities, which suggests that there could be hydrocephalus. And then also, if patients have a lumbar drainage, if they have a lumbar catheter in, one could actually measure, or rather bypassing the lumbar catheter, one could measure the opening pressure, which will also suggest that this patient has high flow. Yes, sir. Hello? Hello?
Yeah, go ahead, please.
Okay, that's it could be from hydrocephalus because there will be an high flow opening pressure, like an high pressure on lumbar catheter insertion for lumbar drainage. And then clinically too, the patient would also present. Clinically, there could be features of raised intracranial pressure, where the patient could have altered sensorium, where the patient could also have other clinical manifestations. But usually, diagnostically, imaging studies will show that this patient actually has hydrocephalus, and then the passage of a lumbar catheter for possible lumbar drainage would also show the opening pressure to be high in such patients.
All right. Thank you very much for the attempt. Someone else asked, in your practice, has CT cysternography been of recent help in localization where indicated? Do you have any challenge getting this done by your radiology colleagues in terms of expertise?
Hello, sir.
Hello, did you hear me?
No, sir, I didn't hear the question.
I said, in your practice, has CT cysternography been of recent help in localization where indicated? Do you have any challenge getting this done by your radiology colleagues in terms of expertise?
Okay, thank you, sir, for the question. Yes, sir. So from my experience here, CT cysternographies are usually, I've not seen that being done for any of our patients. Usually some of the things that we rely on are usually from clinical as well as neuroimaging. One of the challenges here are sometimes patients might not be able to afford, doing this investigation, and as such, so we rely on clinical clues as well as bedside and biochemical testing for these patients because of financial constraints on the part of the patients.
All right. Okay, thank you. To the first presenter, what time duration is acute and delayed based on your classification?
Sorry, I didn't get the question, sir.
What time duration is acute and then delayed? How do you, based on the time duration, how do you classify between acute and delayed?
Okay, thank you, sir. active presentation occurs within 1 week of trauma, while the delayed presentations usually occur after 1 week post-injury.
Okay. Okay, thank you very much. I think they've made some good attempts at answering these questions. For want of time, at this point, we need to introduce our senior faculty for this webinar, no other person than Professor Raji Mahmood. Professor Mohammed Raji Mahmood is a professor of neurosurgery who obtained his medical degree from Ahmadu Bello University, trained in neurosurgery at Usman Dan Fodio University Teaching Hospital, and is a fellow of the West African College of Surgeons. He further completed his fellowships at the University of Virginia and the Chicago Institute of Neurosurgery and Neuro Research, and also in the neuroendovascular surgery at Hyogo Medical University in Japan. Professor Mahmood made history as the first African to serve as chair of the Young Neurosurgeons Committee of the WFNS between the years of 2009 and 2013. He has held several leadership roles within WFNS and across Africa, including key positions in the CANS and NANS, contributing significantly to neurosurgical development on the continent. He established and strengthened neurosurgery training programs at the National Hospital Abuja, Ahmadu Bello University Zaria, and supported program development in Sokoto. To date, he has trained over 30 neurosurgeons, authored 10 book chapters, and published more than 60 peer-reviewed articles, including innovations in surgical technique. He's also a recipient of a presidential commendation in 2018. Currently, Professor Mahmood serves as the Chief Medical Director of National Hospital Abuja, having been appointed by the President of Nigeria in 2023. At this juncture, we want to welcome our senior faculty for this webinar, Professor Mohammed Raji Mahmood. Sir, please, you have the floor now.
Thank you so much, Dr. Kelechi and Dr. Mayowa and the rest of the participants. First, let me apologize to you for joining in late. I was traveling. One of our senior colleagues, who is a pediatrician actually, and the immediate past CMD of Pediatrician Hospital, Katsina, passed on. So we had the burial was yesterday when they brought him back into the country. So I was transiting back to Abuja. And even now, I'm sorry, I may not be able to stay too long because I have an assignment that was just given to me as soon as I landed. So I may have to leave you in a short while. But I was able to catch the presentations at the second leg of the presentation. I must say that it was a very, very impressive presentation as far as I'm concerned. The presenter was able to touch all that you would need to know as either a young practicing neurosurgeon or a trainee neurosurgeon. As a neurosurgeon, you will come across CSF fistulae, CSF leaks every now and then, most especially the traumatic types. Once in a while, you'll come across the spontaneous ones, usually during long-standing hydrocephalus or cases of skull base tumors or skull base infections. So you come across those spontaneous CSF leaks. It is not as rare as it sounds. It actually does happen every now and then, or we come across them every now and then. But then it's very, very important to really differentiate the two and to know that each of them has a different way of management. just like the presenter has mentioned. And getting a diagnosis early or in good time is very, very paramount. And during surgeries, suspecting that a breach of the dura has occurred is very important, so that you are able to repair those that you can repair. Typically, if where you most often we have these cases are in spine surgeries, where when you have a thinned out dura, during the time of dissection of your soft tissue, to expose maybe the areas of the discs, the intervertebral locations. A number of times, because of the adherence of some of the soft tissues on the dura, which has already been stretched, surgeons end up creating some nicks inadvertently on the dura. I would tell you that this has even happened to me, let me say about 3-4 weeks ago. So you need to know, more especially when it comes to that of the spine, when to repair and when not to repair. That's very important. If it's a posterior tear that you can directly see and directly identify, and also be able to identify the nerve roots, then it's good for you to repair under direct vision. But there are times when it's not directly within your sight, or it may be within your sight, but it should be at a very precarious position. So that's when it's anterior or anterolateral. In such cases, it may be a bit of difficulty to repair. In an attempt to even expose it, you may end up tearing further the dura, creating a bigger rent. So in such a case, it's good to just find some other means of repairing such a tear. Some of these have been described by the presenter, where you can use some fascia to apply on that space. And if you have a glue, that's good. You just use that glue to attach. Or in some instances, when you can't find a glue, that blood patch she mentioned has worked so well for me. So I just apply a fascia there, keep it. When I'm about leaving, when I'm about closing the wound, that's when I get some good quantity, usually 10, 15 mils of blood, and spread around that area. That's on top of the grafts that one had laid. So that serves as a glue. And then with the tamponade, eventually after closing that wound, a lot of times it seals. And when it's during cranial surgeries, it's better most often, because access is better most often in cranial surgeries, and you may be able to close those areas of leaks fairly well, most especially if it's anterior cranial. But there is a notorious segment when it's still cranial, when you are doing posterior fossa surgeries. A lot of times people may not even detect that, yes, there's a rent until after they have closed, and then the patient develops a pseudomoningocele. And that, I think, likely because of the gravitational push or pull around that area, the CSF leaks around the occipital regions or suboccipital regions are a bit difficult to heal. Most, like the presenter said, most traumatic fistulae or leakages seal up within a week. But sometimes for the suboccipital leaks, it might last much longer. So But basically, I would say I'm really impressed with the presentations that she has made. A few of the diagnostic armamentaria, we may not be able to have them here. So it is very important for us to have high index of suspicion. For instance, if we are talking about the beta-2 transferrin tests, it's not likely that you'll be able to have a lot of centers being able to run such a highly specialized tests. And even if they would, it will be extremely expensive. So not many patients will be able to afford that, considering the fact that most of our patients pay out of pocket. The CT cystanogram, which as of today is the gold standard worldwide, is not readily done because the technique has not been readily adopted or learned by our radiological colleagues. And I'm happy one of the participants asked that question. EOHexol may not be as readily available, and when it is, the radiologists or radiographers are not able to, they have not gotten that skill to pass a lumbar drain, push in that contrast, put the patient in the appropriate positions, and do the scanning at the very thin slices that is required. Those slices are usually 0.5 to 1 millimeter thickness. So, and even the machine that would be able to do this, not all machines are able to do that. A lot of centers don't have, use 32 slice machines, which may have difficulty giving you those tiny, tiny slices that you need with 0.5 thickness that you would need. So you'd see that not all centers will be able to academically diagnose CSF leakage, but clinically, yes, you can easily do that. As neurosurgeons, we are trained to detect such. The presenter mentioned one of the clinical signs, which is a target sign. Yes, target sign, halo sign. Okay, they're all the same. Or donut sign. But I have seen young colleagues and sometimes medical students that when you're talking about spontaneous CSF fistulae or fistulae that have lasted, that have been on for more than a couple of days, mentioning such kind of signs, the halo sign, the target sign, or donut sign. Please, once you mention that, the examiner knows that you really do not know what you're talking about. These signs are only seen during the acute phase of a traumatic CSF fistula. Once it takes a couple of days, the bleeding is expected to have subsided or has completely stopped. The blood-stained CSF, that's the xanthochromic CSF, could have started clearing. So you may not be able to see that classical sign that, you can identify as a target sign or halo sign. As of then, the CSF has more or less cleared almost back to its normal characteristics. So please be wary and be very deliberate when you are mentioning target sign. So basically, I think those are the few things I would say. I guess the presenters deserve a huge applause from us. They have done well. And I must say, Dr. Kelechi, I liked the way you coordinated it, the way you were able to summarize what the presenter had said, presenters have mentioned is quite good. And you guys should keep it up. I'm quite impressed. Thank you.
Thank you very much, sir, for finding out time out of your busy schedule to join our webinar today. I know you're a very busy man, but you found the time. Your
It's a pleasure.
valuable insights and guidance. Your perspective continue to shape and inspire the next generation of neurosurgeons. Thank you very much, sir. We appreciate, sir.
Thank you so much. Appreciate it. Thank you.
We also want to recognize Professor Komolafe, who has been with us. I think the presenters are his children, direct
Oh,
children.
wow. Prof. Komolafe, good day, sir.
Is he still with us? I can't find him again.
Dr. Ndukuba, I'm not sure. I think he has left, but Dr. Balogun can speak on his behalf.
Okay.
He's one of his boys from Iran.
Okay, Dr. Balogun, do you have anything to tell us from the board?
Good afternoon, the YNNF officials and the professors in charge of this meeting. My name is Dr. Balogun Simon. I'm a consultant neurosurgeon at OETS-IFE, and my boss also was in this presentation throughout, but I think he had to leave not long ago. What I just want to say is on his behalf is that we thank the YNNF committee and the organization of this program for the opportunity to present this topic. We commend our residents for their efforts despite the initial network challenges that made hearing difficult. I would thank everybody for coming, and we say thank you. That's what I'll just say as a message from the boss.
All right. Thank you very much. We also want to recognize our senior colleagues. There were also some international colleagues that joined us, I think from Ghana also, but I think probably some of them left. But we appreciate the presence of our senior colleagues. And I don't know whether any other person has any contribution to make from our seniors. Any other contribution? All right. For want of time, in the absence of any, I would really like to sincerely thank the two speakers for their excellent presentations and the efforts invested in preparing for this.
Sorry, Dr. Kelechi. Sorry. Can you hear me?
Yes, I can hear you, please.
Yeah, thank you very much, everyone.
Okay.
I just want to find out from Dr. Simon because part of the objective of this program, apart from academics, also for collaboration. I think one of your residents, I think Dr. John made mention that one of the patients that was managed had beta-2 transferrin, which was positive. So I want to find out, do you actually do beta-2 transferrin for patients with CSF leak in your center? And how often do you do it? Do you do it routinely? And what facility do you use within the center or outside or anywhere? Thank you very much.
Thank you.
Thank you very much for that question, sir. We don't routinely do it, although we have a point of care examination, point of care laboratory service that is manned by the specialist chemical pathologists. So sometimes they're able to get some of these more rare reagents to do some of these tests. So occasionally we're able to do it, but it's not a routine practice actually for us to do it.
So that facility is located in Ife?
Yes, within the hospital actually. And they're able to do some advanced laboratory investigations that otherwise you may not find in a routine laboratory system of the hospital.
All right. Okay. Thank you very much.
Interesting. Yeah, thank you very much. Any other contribution? Okay, sincerely, we want to thank the two presenters. I think they've done excellently well, and they've put in a lot of effort in preparing for this session. And we also want to thank all the contributors and especially our faculty. Yeah, so we thank every participant that have joined and contributed to this discussion. We appreciate your engagement. This is what makes this forum vibrant and impactful. So at this point, I I need to hand over to the chair of the YNNF to just conclude the session or close the meeting. Are you there? Dr. Mayowa?
Yeah, Dr. Clayton, I think you may need to round off. I think she has an emergency in the theater now.
It's okay, okay. So actually, this is our first webinar of the year. We look forward to a year filled with rich academic exchange, stronger collaboration, and continued professional growth within the Young Nigerian Neurosurgeons Forum. On behalf of the ESCOs, I want to thank everyone for attending. We wish you a very productive week ahead. Thank you all and good evening.
Thank you.
Thank you very much, everyone.
Thank you so much. Yeah, bye-bye.
Thank you.
So, Dr. Simon, our greetings to Professor Komolafe.
Yes, you get the message.
Yeah.